Everyone. Welcome to this Mito webinar. We hope you leave today feeling encouraged and better equipped to understand Autosomal Dominant Optic Atrophy, or ADOA, a type of mitochondrial disease. If you take away just a few practical ideas, helpful tips, or a fresh way of thinking, then we've achieved what we set out to do. Before we begin, today's session will run for about 60 to 75 minutes. You're welcome to submit questions at any time using the Q&A box. We'll do our best to answer the questions at the end of the session. The session will be recorded and published on the Mito Foundation website and our YouTube channel. Some parts of the webinar, such as the Q&A, will be excluded from this published recording. If you experience any technical issues, support is available through the chat. A team member will do their best to assist you. I'd like to begin by acknowledging the traditional owners on the lands on which I am joining this event from today, the Wiradjuri country in regional New South Wales, a part of Australia. I pay my respects to elders, past and present. I would also like to acknowledge the traditional owners on the various lands around Australia and around the world on which you are all located today, and the Aboriginal and Torres Strait Islander peoples participating in this event. I acknowledge the Indigenous peoples on all lands around the world that we call home and the injustices they have faced under colonialisation in all its forms. Mito Foundation acknowledges people with a lived and living experience of Mito, particularly ADOA, and those who love and care for them. Each person's journey is unique and a valued contribution to our commitment to end suffering from Mito. We respect and value the generous contributions which assist us to continually shape the work we do at Mito Foundation. Hello everyone, welcome to this webinar. My name is Clare Stuart and I work as Mito Foundation's Advocacy and Engagement Manager. I'll be hosting this event and guiding us through the speakers. I'd also like to introduce you to Hania, who is Mito Foundation's Research Analyst, who will be monitoring the Q&A function. So please submit your questions during the event, and at the end, we will do our best to answer as many as possible. Tonight, we will hear from Professor Clare Fraser. Then Oliver and I will share some insights from people living with ADOA. We will then hear from Owen Siggs about the genetics of ADOA, and David Mackey will take us through research on ADOA, past, present, and into the future. This will be followed by a Q&A session. The information that gets shared today is for general purposes only. It's not personalised advice, and we won't be addressing individual situations. We recommend always speaking with your health professionals for advice that suits your needs. As with all Mito Foundation webinars, this presentation is being recorded and will be available on our website after the event. Some of what is discussed in this event will be specific to Australia. This webinar is specific to ADOA and information may not be as relevant if you live with other forms of Mito. It's now my pleasure to introduce Professor Clare Fraser. Clare is a doctor who has training in both ophthalmology and neurology, allowing her to provide care for people with conditions that impact the brain and the eye. Professor Fraser is based at University of Sydney's Save Sight Institute. She's dedicated to research into the best ways to diagnose and manage neuro-ophthalmic eye conditions. Professor Fraser will speak about the signs and symptoms of both ADOA and ADOA+. Thank you.
Thank you so much for the introduction and to the Mito Foundation for putting on tonight's event. What I wanted to start off with was, what does a journey through the eye clinic with autosomal dominant optic atrophy look like? Next slide. So I thought I'd start off by sharing a patient journey. So this was a young girl, we'll call her Anna. She was an 18-year-old girl who came to see us in the clinic, and she described to us that she'd been slowly having a worsening of her vision over about 5 years that she'd noticed. She had been to see her optometrist, who wasn't unable to get her vision back to normal with glasses, and she was starting to struggle at university, particularly in the lecture halls. She was otherwise well, and she was neurologically normal with no other associated illnesses. Interestingly, her mother and her maternal uncle had been diagnosed with a condition known as normal tension glaucoma, affecting their optic nerves in their eyes. Next slide. So when we see her in the eye clinic, we do a visual acuity measurement, which is seeing how well she can see in the distance. And we record this as a fraction of numbers. So as I've written here on my slide, right eye 6/18 means that Anna could stand 6 meters away from a letter and read a letter that someone who had otherwise normal vision could stand 18 meters away and still read. And her left eye was a little bit worse, measuring at what we would call 6/24. I've got some pictures here of her optic nerves. In the center, you can see her optic nerves with the blood vessels coming into the eye, and that whole disc area should be nice and pink. But hopefully you can notice that there's a little bit of a wedge on that circle that looks paler than the rest, and that tells us that she has some optic atrophy. Next slide. So when we see a patient like this, we will often do extra eye scans with a machine known as an optical coherence tomography, which I'll refer to as an OCT for short. And this actually gives us a measurement of the optic nerves, and it gives us a printout, which I've shown here. On this printout, where you can see what look like circles with pieces of pie, where that's colored in red means that Anna's nerves are thinner than they should be for someone of her age. And so this scan helps us confirm that she has thinning or atrophy of her optic nerves. This prompts us to do an MRI scan of her brains and her eyes, looking to see if we can find anything that would be putting pressure or causing that change in her optic nerves. We will also request some blood tests looking for nutritional deficiencies. In particular, B vitamin deficiencies can cause this type of optic nerve change. We may also look for chronic infections or other forms of chronic inflammation in her nervous system that could give a similar picture. If all of these things are otherwise normal, this is when we might consider genetic testing. And in particular, in Anna's case, because she had a family history of other optic nerve disease, this was quite high on our list of things to check for. Next slide. So she did have genetic testing for autosomal dominant optic atrophy, and this is a condition first described in 1959 by this gentleman pictured here in Denmark. And he described this in several cases, and finally we have found that these are due to changes in something called the OPA1 gene, which hopefully Dr. Siggs will describe in more detail for us. There have been others described. This is autosomal dominant, and we find it in at least 1 in 50,000 people, and often it is misdiagnosed as normal tension glaucoma, and that ties in nicely with the way Anna presented with her family history. Next slide. So what might be the first signs? So autosomal dominant optic atrophy might first become noticeable in childhood, with children saying that they can't see the blackboard at school. It can occasionally present earlier with children failing their preschool visual screening tests that we have in Australia. Sometimes it's in the teenage years when people are going for their driving license test that the low vision is first noted. And in some cases, the patients may present much later in their 40s and 50s. The vision loss can be quite mild and may not even be noticeable to the person themselves because it's happened so slowly. And now the optometrists have got those OCT scan machines. They may actually find signs of atrophy before someone has really noticed a significant change in their vision. So sometimes we're seeing patients diagnosed in the optometry clinic. Next slide. We will check the visual acuity, where you read the lines off the chart in the distance as well as up close. We may also do an Ishihara color vision test, which you can see here on the slide, where you're reading colored numbers off the plates, and this will show us if there is a color vision deficit, which can sometimes happen. We'll do a visual field test where we're actually checking your peripheral vision, and we might look at the pupil responses. So there are several different tests that you might have done in the ophthalmic clinic. Next slide. As part of our eye exam, we look at more detail at the optic nerve, a bit like I showed you those pictures for Anna. I've got some pictures here showing what we call a control or a normal patient on one side, and then a patient with DOA on the other side. You can see that there's a difference in the color of the optic nerve in the top pictures. You might see that there are some, there's a scan below with the black line showing the patient's level of their optic nerve, and on the left, that line is in the green zone, which means normal, and in the patient with DOA, that line is dipping down into the red area, showing us that there's thinning. So sometimes these changes can look like glaucoma, which is why these patients may be misdiagnosed. Next slide. In about 1 in 5 patients, there are changes beyond vision in patients with DOA. Hearing loss is probably the most common. We might see droopy eyelids that we call ptosis. And if you look at the picture on the slide up the top, this gentleman has droopy eyelids, and he's using his eyebrows, raising those to try to hold his eyelids open. And we can see weakness in the eye movements called progressive external ophthalmoplegia, where you would have difficulty looking in the directions of up, down, and to the side with your eyes. Arm and leg muscle problems may also be found, which is referred to as limb myopathy. There may be changes in the peripheral nerves, which is called a neuropathy. And in some cases, there may be difficulty with balance and walking, which we call ataxia. Next slide. So the prognosis of what's going to happen with the vision is very variable. The classic teaching was that patients would lose 1 line on the chart every 5 years. And I've put a picture down here of a vision chart, and it shows you the different lines of vision getting smaller. It's very rare to lose vision completely, but the main difficulty we have is that there is a lot of variation even among family members within the same family, let alone even between families. And we also know there might be a difference depending on whether with men being more affected than women. But I'm going to let Professor Mackey talk a bit more about that based on his research. Next slide. This is just a very brief slide from one of his studies from 2007, where they looked at 406 patients looking at the OPA1 mutations that were found in about 2/3 of patients, and they found a very large range of visual acuity between different patients. Next slide. He and his group then did a follow-up study, and they were able to find 69 of those patients and check them again over an average of about 10 years. And what I find really interesting from his study was about 60% had no change in vision over the time measured. But what was also interesting was that depending on the type of mutation in the gene, they weren't able to see any obvious difference in the speed of the vision loss. But again, I'll let him elaborate on this a bit more for you later. Next slide. So what would we do in the eye clinic after we'd made a diagnosis? Of course, we want to make sure there are no other eye problems going on and make sure we're managing those, in particular if there is any true glaucoma. We would test for and manage any nutritional deficiencies, as I've mentioned, in particular the B vitamins. We would provide vision support, making sure that there was the best pair of glasses possible and looking after the rest of the eye health. There have been some papers looking at idebenone, which is a supplement, but the data on this is I'm trying to work out the best way to say this. The data on this has been based on a retrospective study. It's not the best form of evidence, so it's not something we do routinely, but it may slow vision loss, and I think we're waiting for perhaps for more studies to say whether this is something we should be doing for every patient. But what's really exciting now is that we do have some new therapies in trial that are aimed at improving the production of the healthy OPA1 patients in patients with autosomal dominant optic atrophy. And these are just in phase 1, what we call safety trials at the moment, but this therapy is now being tried in human patients. Next slide. So there are several potential targets for treatment, and I believe Dr. Mackey is going to go into more detail in this. So in the interest of time, I will move on. Next slide. There are lots of things on the internet about different types of optic nerve regeneration therapies, stem cells, and there is a lot of what I will call misinformation and treatments that really at the moment aren't in mainline sort of human testing at this stage. But there are certainly some exciting things that will be coming in the future. Next slide. The main thing I wanted to highlight for certainly our Australian and New Zealand patients is that there is this trial, which we're calling the Myrtle study, being run through the Save Sight Institute here in Sydney, Australia. And there is also a trial site in Melbourne and in Auckland. There will also be sites, I believe, in Cambridge and perhaps in America. So this trial, we're looking for patients aged over 18 with confirmed OPA1 genetic changes, a vision in the range of 612 to 660, and mild to moderate disease based on OCT measurements. So we're looking for these sort of patients that have got a little bit of vision loss but aren't too severe, and these are the patients that will be offering entry into the trial with some of this new therapy. And I've put the contact details there for our trial coordinator if you want to get in touch with us to see if you or anyone in your family might be eligible. So that's just a brief run through of how we see patients in clinic and some of the tests that we do and the things that we're thinking about. I'll hand on to the next speakers, and I'm welcome to any questions later. Thank you.
Thank you so much, Claire. Really appreciate you sharing your expertise with us tonight. I also wanted to thank the people that answered the survey a couple of weeks ago. Mito Foundation sent a very short survey to people who had registered for this event and had told us that they had a lived experience or a personal connection to ADOA. We wanted to be able to bring some of that lived experience into this event. While many people that work and volunteer at Mito Foundation have mitochondrial disease, none of our team had that experience of ADOA. So we wanted to use this to just bring some of those insights here. We asked several questions about what life is like living with ADOA. We'll share a little bit about what we learnt, but we'll also hear from a person living with ADOA, Oliver. What we heard from the survey is that vision loss is only part of the story, or perhaps you could say the tip of the iceberg, which is the picture on this slide. People shared with us that uncertainty and worrying about the future were major parts of living with ADOA. They shared that living with ADOA involves practical challenges, often associated with vision loss, emotional challenges, particularly anxiety and isolation, exhaustion, and fatigue. But all of these also interact with each other, depending on the situation. This quote really stuck out from the survey responses. This was from a parent of a child with ADOA. The uncertainty of progression affects us emotionally and mentally. Our daughter just has vision loss for now, but she may develop other symptoms. We also asked in the survey about what you wanted your healthcare team to know about living with ADOA. Overwhelmingly, you told us that you wanted your healthcare team to take you seriously, to learn about ADOA, but also to be willing to learn. I think we see this from many communities and many people living with rare diseases. We don't expect our health professionals to always be experts in our specific condition, but we want to work with you to understand that condition and learn together. Some people in the survey also said they wanted their healthcare team to give them as much information as possible, even if there are many things that are unknown. People also shared that they wanted their healthcare team to encourage them to seek emotional support and recognize all of those impacts of ADOA that are beyond just the obvious vision loss. One quote that someone shared, I think, illustrates all of this. The doctors are never going to understand everything about every mito condition, but just please be receptive to understanding the lived experience of your patients. We also asked you about advice for others that had been recently diagnosed with ADOA. I think this quote captures it quite well. Someone suggested, an adult with ADOA suggested to others to live life to the fullest while you can still see a little. Whenever I experience more vision loss, I close my eyes and see the beautiful things before me. Look at what you have and not what you lost. Others mentioned hope in the research that is progressing, the need to become an expert in their condition in some way, encouraging others to seek emotional and mental health supports, and focusing on the now as much as you can. Owen is a geneticist and a researcher at the Garvan Institute for Medical Research here in Sydney, Australia. One of his interest areas is how we can use genomics to better diagnose, predict, and treat blindness. Professor Siggs has accepted our invitation to discuss the complex topic of the genetics of ADOA. Thank you.
Thanks very much, Claire. And thank you also, Oliver, for that very powerful articulation of your experience of ADOA. My job for the next 10 minutes or so is to not explain the what, but the how and the why of ADOA, how this happens at a genetic and a cellular level. Next slide, please. So to do that, we have to zoom all the way into our cells and our genomes, our DNA. And just about every cell in our body has not one, but two genomes. Most of the genetic material is stored inside our nucleus. This is a 3 billion letter code, coding for around 20,000 genes, which each create a unique protein. But there's also a second genome in our cells that's kept inside these powerhouses known as the mitochondria. This is a much, much smaller genome, only about 16,000 letters in length, but it still codes for around 37 genes. And there can be thousands of copies of this genome inside every cell, depending on how large that cell might be. Now, errors in either of these genomes can lead to disease. In the case of ADOA, it's due to problems in the nuclear genome, but there are also similar conditions which are caused by changes to the mitochondrial genome. And there's a condition known as Leber hereditary optic neuropathy, which is a well-known example of the latter. Next slide, please. So back to ADOA, this is a problem that originates in the nuclear genome, and it's most commonly due to changes in a gene known as OPA1 or optic atrophy 1. Now, like most genes in the nuclear genome, we have two copies, one inherited from our mother and one inherited from our father. And both of these copies are used to generate RNA, which then is used to generate protein, OPA1 protein. But in most cases of ADOA, one of these two copies of OPA1 has an error, and that results in about half the amount of RNA and protein produced in an ADOA cell as would be produced in a normal cell. And this was a fundamental discovery made about 25 or so years ago by two groups independently that's completely transformed how we diagnose, understand, and treat ADOA. Next slide, please. So what does the OPA1 protein actually do? Well, even though it's encoded by the nucleus, after it gets produced, it gets transported into the mitochondria. And there it forms these beautiful ring-like structures. And those structures in turn control the shape and the internal surface area of the mitochondria. So a good way to think about this is like solar panels on your roof. The greater the surface area, the more panels you can stick on your roof, and the more energy that you can produce. So in the mitochondria, the internal surface area is a critical determinant of how much energy they can produce. Next slide, please. So I've told you that ADOA is caused by problems with OPA1, which then causes problems in the mitochondria. But why do most people with ADOA only experience vision loss? Aren't mitochondria important in every cell? Well, that's true, but the reason for the selective symptoms are that some cells require more energy than others. And in particular, the cells which connect the eye to the brain via the optic nerve, these are the cells which have some of the highest energy demands in the entire body. And if they don't make enough OPA1 protein, they don't generate enough energy, and they can end up dying, and that leads to the characteristic vision loss. There are other sensitive cell types as well, including those involved in hearing, movement of the eyes, eyelids, and limbs, and these are also affected in the ADOA plus spectrum that Professor Fraser mentioned earlier. Next slide. So how is this condition passed through families? Well, it's all in the name, autosomal dominance. It simply means that it's passed down from a parent to a child about 50% of the time. It doesn't matter if it's the mother or the father. If either parent has ADOA, then there's a 50% chance that their child will inherit the genetic change which causes it. It's also important to mention that in some families it can arise spontaneously, so for the first time in that particular family, but beyond that, the same pattern of inheritance will follow. Next slide. Now that's what we learn in the textbooks, but of course the real world is never as black and white as this. And there are three important observations to mention, which Professor Fraser has mentioned and Professor Mackey will elaborate more on. First of all, not everyone with ADOA has a variant in the same gene. OPA1 is the most common, but there are others. Secondly, not everyone with a variant in OPA1 gets ADOA. There are some people that have a disease-causing variant who are completely asymptomatic. It can vary from family to family. And thirdly, of those individuals who do get ADOA, the severity can differ a lot, even within the same family with exactly the same genetic variant. It might mean the difference between somebody in the family developing symptoms at a very young age, or another person in the very same family developing it late in adulthood. The reason for this is still being figured out, but we can say with some certainty that OPA1 is not the whole story for ADOA, and that we think that changes in other genes are likely to explain some or all of this. Next slide, please. So a simplified analogy for this is to think of genetic risk in terms of the way you think about currency. So a change in the OPA1 gene is like a $5 note. It has a really big impact on your risk of ADOA, and it gets you most of the way there most of the time. Although to really get full-blown ADOA, you might also need another dollar's worth of genetic spare change, so to speak. Or in the case of ADOA plus, you might even need another couple of dollars. Next slide, please. So just to quickly illustrate the potential benefits of having a genetic test, this is Kim and her family pedigree. Kim's a board member at the Cure ADOA Foundation in the Netherlands. She's also a doctor and a researcher, and she also lives with ADOA like Oliver does, and many of you do, as do her brother, her father, and her uncles. And as has been mentioned already, there can be a lot of variation in the severity of this condition, and that's certainly the case here, particularly in Kim's grandfather, who was a suspected carrier of the genetic variant, but he lived a long life without experiencing any visual symptoms. So some of the reasons why families like Kim's might want to pursue genetic testing, certainly diagnostic certainty is a big reason, and using that information to then determine who else in the family might be at risk and in need of further monitoring. For a young woman like Kim, she might also be considering having children, in which case pre-implantation genetic diagnosis and in vitro fertilization might be of interest if that is accessible to you. And in other cases, genetic testing is often a requirement to access some of the emerging clinical trials we've heard about from Professor Fraser. Next slide, please. So just to wrap up then, ADOA, it's one of those conditions that really does capture how genomics is transforming the face of medicine. So firstly, on the diagnostic side, 30 years ago, we had no idea what caused ADOA. And to sequence a human genome to figure that out would have taken an international team of doctors and scientists 13 years and $3 billion. Today, that's something that we can access in a specialist clinic, in fact, even better technology, and we can get an answer in as little as a few weeks. And in some parts of the world, certainly including Australia and others, that testing can even be taxpayer funded. Then secondly, on the treatment side, so thanks to those genomic discoveries, we now understand the underlying cause of diseases like ADOA, and companies like PYC and others have used that knowledge to develop ingenious new treatments, and these would have been unimaginable a couple of decades ago. So it's a real success story in the making, something that rare disease communities, researchers and biotech companies should be very proud of. And final slide, please. Is just a plug before I let you go for a research study that we're running. It's for Australian families with a known or suspected rare disease or monogenic disease, so similar to ADOA and others. We'd especially love to hear from families or their treating doctors who might have had genetic testing but don't yet have a clear genetic diagnosis, in case there's a clinical or research pathway we might be able to offer to help you. So in case you're interested, please get in touch. And with that, I can pass on back to Claire and Professor Mackey.
Thank you so much, Owen. And amazingly, we're running right on time, which is fantastic. We will have time for questions. So I just wanted to remind everyone that if they've got questions in response to Claire, Oliver, or Owen, please consider submitting those in the Q&A now. While we're waiting for your questions to come in, I'd love to introduce Professor David Mackey. He's an ophthalmologist and a renowned international researcher in the genetics of eye disease, including 2 rare diseases falling under the mitochondrial disease banner. He works with the Lions Eye Institute and the Centre for Eye Research Australia. Professor Mackey will speak about what research has been done in ADOA, current research underway, and what the future might hold. Thank you, David.
Thank you very much, Claire, and I'd like to acknowledge the Mito Foundation for the wonderful support and also acknowledge the lived experience for people with ADOA and their families. Next slide, please. I'd like to acknowledge the funding support we have received from the Mito Foundation and Australian Vision Research, which I'll talk about later, and the other funding bodies. And I have received consultancy fees from PYC Therapeutics. Next slide. You have heard earlier about Leber's hereditary optic neuropathy, and this was a disease that Professor Theodore Leber, shown on the right here, first described back in 1871, and he recognised that there were patients with optic atrophy, and this was running in families. Now, the reason he described this was he was in a department shortly after the invention of the ophthalmoscope that allowed people to look inside the back of the eye of a person and come up with what might be the explanation for their vision loss. So over the century after he made this observation, and the name became attached to, his name was attached to the disorder, it was observed that Leber's hereditary optic neuropathy seemed to affect men more than women. It often occurred with a sudden loss of vision, usually in early adult life. Most people were severely affected and became legally blind, but some could recover. And it was often passed through the female line, and subsequently this was explained when a mitochondrial DNA mutation was discovered, and therefore with the reason that it was passed from mother to child through the mitochondria. Next slide, please. It was in 1959, as you've heard, that Paul Kjær in Denmark noticed that some of the optic atrophy families were different, that men and women were affected equally. It was autosomal dominant transmission, as Owen has described, and there wasn't usually a sudden loss of vision, and textbooks tended to quote that a lot of people were legally blind, particularly older family members. Now, in the year 2000, two studies came out identifying the OPA1 gene, including some of the large families that Paul Kjær had identified. But even now, it's not always clear to distinguish if someone has Leber's hereditary optic neuropathy or autosomal dominant optic atrophy, and sometimes the conditions and the diagnoses can be mixed up, and it's with genetic testing that we can be more definite about which of the two conditions people have. Next slide, please. Next slide, please. I had done my original research work on Leber's hereditary optic neuropathy, and in that time I realized there were a few families that seemed to have dominant optic atrophy, but it was only when we started doing the family trees of these families that we realized there were some very large families in Australia. Now, with the collaboration of Chris Engelhern and Carmel Toombs laboratory in the United Kingdom, we actually identified the mutations in some families. And one of the families in Australia actually had the complete gene missing, as well as parts of the chromosome around that gene. And this helped clarify that the mechanism of this gene mutation causing disease was because it was missing completely, and therefore no product was being made through the mRNA and protein pathway that Owen explained in this family. And we thought that this haploinsufficiency was the explanation for most OPA1 families, but not necessarily all. Next slide, please. Now, Amy Conn, who is in charge of the medical retinal clinic at the Ioneer Hospital in Melbourne, back in the early 2000s, did this work as her master's thesis. And Amy very diligently helped me chase up all the Australian families where we identified the OPA1 mutation in 2/3 of these. And we were mainly seeing people who were adults but went down to 4-year-old children and elderly people. And the median visual acuity was around 6/21. So not in the driving level of vision, but not in the legally blind level of vision. But there were people who were better than normal and people with severe visual impairment seen across the families. Now, one thing we were really particular about was we tried to examine every brother and sister of anyone who had the vision loss of dominant optic atrophy. And this allowed us to see a lot of people who were normal, but 17% of the people who were in the normal range actually were carrying an OPA1 mutation. And this is very important because it means that there are people who think they are unaffected who could pass this on to their children. Next slide, please. This is a small segment of a family where I've got the photos of the optic nerves of the grandfather at the top, his son in the middle, and grandson at the bottom. Now, grandfather's vision was 6/24 and 6/36, so fairly significant vision loss there. But his son actually has a visual acuity of 6/6 or 20/20 vision, and would be regarded as quite normal and probably was reassured that he didn't have the condition. Now, unfortunately, when his son grew up, we noticed that his son's vision was 6/18 in both eyes, so moderately visually impaired like his grandfather. And this is an example I'd like to highlight. Actually, we observed several times in Australia. And this is why it is important for every person in a dominant optic atrophy family, where we know there is an OPA1 mutation in the family to actually get tested themselves to find out if they are at risk of passing this on. And then it's possible to go through a program such as the IVF predictive genetic pre-implant genetic diagnosis to find out whether they can prevent their children being affected. And we're now recontacting family members in Australia to alert them of this possibility that some may not be aware of. Next slide, please. Now, an example we have of one of our very large families, we tracked back 7 generations, and in fact, the patriarch on this pedigree at the top here, so we've got lots of little squares being men, circles being women, and if they're dark, filled in shadows, they had optic atrophy, and we put a plus or a minus to show if they were carrying the OPA1 gene. So you can see how the unaffected gene carriers fit in this family. And when we go back to the original founders, we don't know if they were affected or not. And in fact, the patriarch was born in 1788, so nearly 100 years before Theodore Lieber even described the condition. Next slide, please. So one advantage, and you've heard this from Claire already, was we had seen a lot of people where we found their original clinic notes and we looked at our current examination. So this is not in a precise scientific way, but we had a reasonable assessment of what people's early and more recent vision was. And the average time we followed was over 10 years. Now, of the families, if we look at less than a line of vision in change, 43 people or 62% were pretty much similar to where they were 10 years earlier. There were, however, 19% of people had dropped by 2 lines and 9% of people more than 2 lines on the vision chart. And then some people, to our surprise, actually improved by more than a line. So vision can go up or down. And what we would like to do is actually work out how much has the vision changed in these same people if we go back and look at them now, 20 years after this earlier assessment. Because on average, the people at the beginning of the assessment and at the end of the assessment, the median vision was 6/18. So although we think there is some progression, we're not sure if this happens with everyone, and we're not sure how much of this might be confused with the normal vision loss we see in people without the OPA1 mutation, where in your 40s, most people start to need reading glasses, and in our 50s, 60s or 70s, people may develop early cataracts, and after the cataract surgery, there were definitely people that I've contacted recently who said their vision went back to where they had been earlier. So this is part of our future research that we hope to do. Next slide, please. Now, this is an example from one of Amy's papers where we list all of the large families that we identified. Now, with PYC's support, I had been going back and contacting family members in families that were eligible for the treatment trial where we knew definitely this haploinsufficiency was occurring. However, I need to point out that some of our large families did not meet this proof of the mechanism of the optic atrophy, and unfortunately, therefore, were not eligible to go in the trial. So although you may belong to an optic atrophy family, not all families with an OPA1 mutation could go in the trial, and I'm happy to talk to any family members who might want to know about this if they were involved with our work. Next slide, please. So the new research underway in Australia actually came about for me being involved in contacting family members and informing them of the PYC trial that was underway in Australia and telling them how they could participate in that. But I had a lot of long conversations and looked at some of the questions people asked. And the big one was, why are some family members normal and able to see the bottom chart, let alone the vision chart? And why are some other people severely affected? And could we actually determine this? And do people really lose vision? So next slide, please. Now, although this is referring to the PYC, as you've heard from both Owen's talk and from Clare's talk, there is the Stokes study in the Northern Hemisphere underway. So what this involves is getting an injection into the eye, and although people may have some concerns about this, we inject thousands and thousands of people every year to treat age-related macular degeneration. So it's a fairly standard procedure in eye clinics. The people who are eligible need to be adults in Australia, but the Stokes study, I gather, is also recruiting younger members. And you need to have an updated genetic test to show that you have one of the eligible gene mutations. And this means people we saw 20 years ago need to be retested. And the vision needs to be in the level between what is good for driving a car and what is severe enough to be legally blind and be getting the blind pension. It's a bit borderline with that exact level, and therefore we need to precisely examine people to see if they meet the criteria to go in the trial. And we currently have sites in Melbourne and Sydney in Australia, but also Auckland in New Zealand, and there are some other sites in other countries around the world being developed. Next slide. So what did I realise we needed to sort out? So I'm a bit more old-world than Owen, and I used the $1 coin and needing a few extra cents on top of it, but I think his large number of coins and the $5 note are probably more accurate. So we're going back to all the families that we had seen previously, and we have collected DNA and done extensive analysis on that DNA. But we want to run some new analyses to look at what other genes might be the small change genes that tip someone over the line for having poor vision versus someone having virtually normal vision. And the first and most obvious one, are there variants in the good copy of the OPA1 gene, the variant that you get from your parent who isn't part of the extended OPA1 family? And we know there are some variants in the upstream region that determine the regulation of this gene, and we want to look at those markers to see if they influence it. Now, when we talked about the Leber's hereditary optic neuropathy, we know that there are variants in that gene that determine if someone is at risk of losing vision from Leber's optic neuropathy. But there are some mild variants of those mitochondrial genes that influence the likelihood that someone will lose vision from Leber's hereditary optic neuropathy. And we want to test if those variants could be explaining the mild and the severe variants in our ADOA families. And then the final group, an area that Owen's been working on very extensively, are all the small change variants that put someone at risk of glaucoma, and whether the genetic risk score for getting glaucoma is influencing a person's risk for developing severe optic atrophy. Now, fortunately, we can run all of these analyses off the one genetic test, and this work was funded by Australian Vision Research, and we hope to be able to run this project in the middle of this year and look at all the family members we've seen. We would like to recruit new family members, particularly people where we have severely affected and mildly affected individuals in the family. And we'd like to re-examine people that we saw, particularly those where we've got vision from 20 and 30 years ago, to see how much this changes over the very long term. Next slide, please. Now, Lisa Kens, who's a genetic counsellor and orthoptist who's been working with me in Melbourne for over 20 years, And I know almost all the Australian Leber's optic neuropathy and dominant optic atrophy families, and we're happy to talk to anyone in the families, particularly younger family members, to help arrange for them to get referrals for genetic testing and referral to genetic counselling services and the possibility of genetic screening possibilities using the IVF program to avoid passing on optic atrophy to their children. And we're happy to talk to people privately offline about this. You can contact me here, although probably more ideally through the organisers of today's meeting, the Mito Foundation. And thank you very much for the opportunity to talk.
A few resources that might be of use. I have mentioned the Cure ADOA Foundation and the ADOA Association, two organisations, small but very committed to making progress in ADOA. Encourage people with lived experience or those that want to learn more to connect with those groups. As you can see, Cure ADOA, more of a European focus, but certainly active around the world, has information in multiple languages. I'd also encourage you to take a moment to check out the Mito Foundation website, particularly if you're located in Australia, but more generally to learn about mitochondrial disease and the different activities that are on offer here in Australia, and to learn more about mitochondrial diseases generally. Also in Australia and New Zealand, we have two organisations focused on inherited retinal diseases, of which ADOA is also classified. It's a member of a lot of different clubs. So Retina Australia and Retina New Zealand, those organisations have generously shared this event with their networks. So that might be another good source of information. And Mito Foundation will continue working with those two organisations as well. I also just want to plug, particularly for those in Australia, hence the map of Australia, that Mito Foundation maintains a Mito registry. This collects minimal information, so contact details and some information about your diagnosis, to really support clinical research. It helps us understand how many people have ADOA in Australia, and that can help to encourage research to come here. But more broadly, it helps us to also connect people that might not be connected into groups like David's, although his studies suggest he'll have much broader coverage than we will possibly ever have for ADOA in particular. But a chance to get connected and find out about perhaps mito research that is not focused just on ADOA. So really encourage you to have a look at that. Feel free to reply to the emails that you've gotten for this event, to ask any questions you have about the registry, and really encourage you to consider taking part. It's a really important way that you can support research that's happening today and into the future. I want to acknowledge that this education initiative was supported by PYC Therapeutics. On the screen is their logo. I just want to acknowledge and thank them for their grant to Mito Foundation that has allowed us to put this on. As you've heard tonight, PYC is developing a new therapy for people with ADOA, but PYC were not involved in decisions about the content of tonight's event. So lastly, I'd just like to finish by thanking our amazing speakers who have given up their time. So Owen, David, Claire, and Oliver, all of you contributing your expertise has made this event what it is. I really appreciate that. And on behalf of everyone that has either attended live or will watch the recording, we know how much you give each day in the clinic, in the lab, and then extra events like this. Thank you everyone for joining us. I look forward to sharing this recording with you later after the event. And I wish you well with the rest of your evening and your day. Thank you so much.
Thank you.
Thank you.